Good afternoon, everyone. It's my pleasure to share the details on history of ECMO and its statistics. Welcome and happy learning. I have no financial disclosures. The objectives of today's talk are exploring the history of technology and equipment for ECMO, history of clinical trials of ECMO, and history of organizations such as ELSO, SWAC ELSO, and ECMO Society of India. I will briefly deal with the ECMO statistics as well. The development of ECMO is really fascinating. It is like a story. As you are just getting introduced to the field of ECMO, ECMO stands for extracorporeal membrane oxygenation, which is a technique of cardiopulmonary bypass, tends to be used for a period of days to weeks to months after maximizing conventional management, and if it is not successful, then only we go for ECMO. The thoughts about exchanging gas with the blood over a period have started over a period of time, or really centuries, as you can see from here. As I could trace back from 1635 to 1703, Robert Hooke, he conceptualized the notion of an oxygenator. Then, nearly after a couple of centuries, Ludwig and Schmidt, they attempted to oxygenate the blood by shaking it with the defibrinated blood and air in a balloon. In 1882, Schroeder and Strasbourg, they used a bubble oxygenator to oxygenate an isolated kidney. In the same year, Frey and Gruber described two-dimensional direct contact ECMO oxygenator, which exposed a thin film of blood in an inclined cylinder. In 1916, discovery of heparin was done by J. McLean. It is another fascinating story. You should read that. In 2029, first whole body extracorporeal perfusion of a dog was done by Rukhnenko and Shuchlin in Russia. This is the picture showing development of the first heart-lung mission for total body perfusion by Brukhnenko from Russia. Then the other very interesting story is about J. McLean, who, as a second-year medical student, discovered heparin at the Johns Hopkins Medical Center. It is fascinating as he developed it while he was a medical student. He extracted the content of a liver, and that's the reason he called it as a hepar, coming from the hepar. So he named it as heparin, having these anticoagulation properties, and people worked on that further. In 1930s, John Gibbon started investigating on the use of ECMO. In his experiments over the next 30 years, uh, three cats survived for 1 year following 2 hours of bypass. Going back to the story, in 1930s, John Gibbon was a surgical fellow at uh, John Hopkins. Then he came across a patient with pulmonary embolism he was looking after. That lady had pulmonary embolectomy. He was looking after her that night. Unfortunately, she passed away. So that led to increasing enthusiasm and thoughts in Gibbon's mind about developing a device which can directly oxygenate the blood in the absence of lung functioning. He continued his experiments afterwards. Mary Gibbon joined him and became his life partner. He was his research assistant. They developed their first heart lung mission. And with that, John Gibbon did uh, operation on a patient with atrial septal defect in 1953. ending 23 long years of apparatus designs and experimentation. Here you can see his previous patient, Cecilia, posing with a plexiglass covered lung 10 years after the landmark operation. That is, now it is in 1963. After Cecilia, two children, John Gibbon operated, they have died. So he abandoned further use of his heart lung mission. I adore his dedication to the human life at that time. He didn't continue with his experiments. Despite his 23 years of dedication and hard work, he felt his mission is not worthwhile to help patients and he abandoned the mission. Then the Mayo Clinic asked his plans for Gibbon's oxygenator, which he shared. They together developed Mayo Gibbon type of oxygenator for the next several years. It was used in hundreds of patients and it saved so many patients by taking them through cardiopulmonary bypass. The mortality rate for intracardiac surgery dropped from 50% in 1955 to 20% in 56 and 10% in 57. So that's how the technique has been perfected with time. The importance and contribution of Dr. Walton Lilly are very well acknowledged. He contributed mostly to the development of a bubble oxygenator he invented along with Richard Dewall in 1954. This was the era of oxygenator development. Lilliher and Dewall, they developed a double oxygenator, you only useful for an hour or two at a time. Then, after a couple of years, Kammermeyer, he developed a silicon rubber oxygenator, which was used by Colombo for doing prolonged surgeries and prolonged bypass, which used to run for hours to days in animal experiments. Then came the era of bubble oxygenators, but these had problems secondary to thrombocytopenia, coagulopathy, hemolysis, edema, and organ failure. This was attributable to the blood gas interchange problems. In 1968, Colombo, an exceptional surgeon, led to the development of a spiral coil membrane lung along with Zapol. It has become very famous and opened up a new era in reducing the surface being exposed to uh, oxygen or the gas. The silicon membrane oxygenator, which is woven now, had no gas interface, but it was useful for weeks to months. It was limited by the diffusion of oxygen through the blood, though. Then, with further development, semi-porous hollow membrane oxygenators were developed. They have been very, very useful. Gas flows through the fibers in this device. It has been made more biocompatible and more efficient, but the problem could be plasma leak across the fibers at sometimes. We do come across this. It increases secondary flow as well. So the non-porous oxygenators, they had a good long-term effect, less of platelet aggregation and minimal hemolysis, current gold standard ones. Going back to the uh, professionals who worked using this ECMO technology, the first prolonged extracorporeal support for the use of 75 hours outside the cardiac theater in 1972 on a patient who sustained road traffic injury or case of trauma was Dr. Hill, Donald Hill. The patient survived. So that was a beginning of a great history. Here you can see the patient and see the size of the membrane oxygenator as well at the same time. The big roller box in front in circular one in front of you as you're seeing, that was a membrane oxygenator, and you can see the whole room was filled with equipment. This was in 1971. Then Bob, around the same time, he used ECMO in children from 1972 onwards. First, he used on a boy, 2-year-old boy, following mustard procedure, and in 1975, the landmark case of neonatal ECMO on Esperanza. It is worthwhile reading the story of Esperanza, and Dr. Robert Bartlett is considered as father of ECMO, as you all know. Esperanza's mother migrated from Mexico and delivered as an illegal immigrant in the city where Bob was working at the time. Baby had meconium aspiration, and her pulmonary hypoxia wasn't responsive to conventional ventilation. So Bob had a look at her, and with the mother's consent, he put the child on ECMO, and she's the first survived neonatal ECMO patient. This was in 1975. She was named Esperanza by the nurses. In Spanish, Esperanza means hope. She remained as hope for our ECMO community for the times to come. And this was Esperanza on her 21st birthday. Whenever we go to US for the international conferences, we tend to see Esperanza coming to the meetings to greet us as well. This is about further development of the cannulae. Uh, Joseph Swanberger, he developed double lumen cannula, which has been very, very useful from all the ages, starting from 3 months to any age in an adult, different sizes, of course, but this has significantly reduced the recirculation time, which you will come to know in course of time. This is the first photo of the organization created by Dr. Bob Bartlett and Peter Rikus et al. At Ann Arbor, Michigan in 1989. All the individuals who have been interested in taking ECMO forward uh, who are assembled in Ann Arbor and discussed about taking it forward, meeting it, and making it as a charter. So this is the inception of ECMO, the birth of ELSO, Extracorporeal Life Support Organization. This was a circuit we used to work on in the 1990s. This is a roller pump ECMO, and the tubing has to be taken off the roller pump and put back again very transiently. This is called as walking in. Some of the adult patients were needing double oxygenators as well at that time. As you can see here, this is uh, about development of further ECMO techniques as it went on. How does ECMO work? ECMO works by the technology of broken leg analogy. Once once a limb is broken, it needs rest, not vigorous exercise to heal. So that is the reason when lungs are subjected to significant barotrauma, it is better to go for a mechanism such as ECMO, where lungs are allowed to rest by minimizing the ventilation while the gas exchange is taking place by a different mechanism. How does it work? How does it work? So in the neonatal population, with the work of Dr. Bob Bartlett, there was increased trust, and the incidence of survival was increasing with ages. So these children were taken onto ECMO and continued to be placed on ECMO. But in the adult world, I will deal briefly about NIH trial, in that the mortality rate was around 90% in the conventional limb as well as in the ECMO limb. Hence, following this, there wasn't much of encouragement for putting adult on ECMO at that time. So the trial was NIH trial, National Institute of Health trial in mid 70s in US. It was a national multi-center trial But most of the institutes at that time who were adopting ECMO were beginners. The intro criteria was PaO2 of less than 50 millimeters of mercury on 100% FiO2, and conventional or ECMO group death was nearer to 90%, as I said. Hence, there wasn't much of encouragement to go ahead with that. Some of the problems with this NIH trial were some centers had no prior experience of ECMO, as the study patient was their first trial patient really. Best and worst patients were excluded, and that was the time of influenza epidemic also. Patients had excessive bleeding, about more than 2 liters a day, and lung rest was not used as well. So with these all these fallacies, as we compare to the current standards, it wasn't taken as a positive study with good results. So as a mortality rate was 90% in both conventional as well as in ECMO limbs. It was a negative trial. So people felt that the death of ECMO. Two group of researchers still maintained their interest after NIH trial. They felt the fundamental idea is correct, needs better case selection and application. One of them was Bob uh, Bob Bartlett. He believed neonates had more suitable pathology and greater healing power than adults. So he continued with ECMO practice in the neonates. In 1980, Bob's practice has grown to few cases per month, and in 1986, there were 18 centers who were established in US, and there was a modified design trial in the USA in 1986. So there was vast improvement over this period of time from 1975 to 1986. In neonates, the success rate came up to 80%. It was a vast improvement from 50% in 1981. Then the Boston Children's Hospital trial came in 1986 to 88 with 19 patients in the trial. 9 were on ECMO, randomized, and 10 were on conventional limb. But the survival rate was 97% in ECMO limb, whereas it's 60% in the conventional limb. When there was a need for a bigger trial, so a UK Glenfield Hospital took up the responsibility of conducting this trial at that time, along with the other centers in UK, which were relatively few, 4 centers. UK collaborative neonatal trial was done from 1992 onwards. Due to lack of funds, the institute is about to be closed, but it came up in the Prime Minister's question time, and there was support received for the funding. Um, as a result of that, ECMO continued at the Glenfield Hospital, which was established in 1989 as Europe's first ECMO program, and continued afterwards. So in this UK collaborative trial of neonatal ECMO, 185 patients were recruited, 93 in the ECMO limb and 92 in the conventional limb. As you can see the results, 63 survived to 1 year, whereas only 37 survived to 1 year. So this is taken as a major positive trial. Glenfield Hospital had interest in ECMO as well, so they continued to do ECMO. This photo was taken towards the end of 1990s, where the adult survivors of ECMO were brought for a get together and sharing their experiences, etc. In the middle, you are seeing um, other ECMO consultant who has been the pillar for the ECMO program in UK in my days. So um, Extracorporeal Life Support Organization, as of 20, last year, December 2021 was this. It has been showing very interesting results about survival. These are the pooled data showing survival rates of up to 77% in neonates respiratory, that too, In the cardiac group, it is around 40% in the neonatal cardiac or pediatric cardiac, whereas the pediatric respiratory is around 60%, adult respiratory again 53 to 60%, and adult cardiac 33%. Overall survival rate was around 66%. From 2005 onwards, there was change in the equipment. People changed from roller pump ECMOs to centrifugal pumps. PMP oxygenators were brought into effect and usage. Proning in the importance was understood. Physiotherapy has become a part of management, and further innovations for biocompatible circuit have started at that time. So Bob Bartlett calls this period after 2006 as a ECMO 2. There was still concern about adult ECMOs at this stage in United Kingdom, as we needed funding for this case of adult ECMO. And another randomized control trial was started in the name of CSER trial, which stands for conventional ventilation versus extracorporeal membrane oxygenation for severe adult respiratory distress syndrome. So, over a period of 5 years, from 2001 to 2006, during my time at Glenfield Hospital, we did this trial where patients were recruited from 68 centers throughout United Kingdom, and they were treated at Glenfield Hospital as the only center to treat the ECMO patients. Conventional ventilation wise, there were 41 in 87 patients, and ECMO was done in 57 patients out of 90 patients. So this was treated as a positive trial. Some patients who didn't go on to ECMO but managed on ECMO principles, they were also added to the ECMO survival limb. Hence, some of the ECMologists continue to express doubts about this positive effect. So to address this, in France, ELIO trial was started. You are all aware of ELIO trial, and Alan Coombs was the principal investigator of this trial. It was also a useful trial, but because of the complexity and the changeover of the patients who have been dying from the conventional limb to the ECMO limb, at 60 days, 35% of the patients in ECMO limb and 46% in the control group died. There is increasing survival reported in ECMO group, but it wasn't statistically significant. If you look at closely at the subgroup classification, it still stands out as a positive trial. But on the overall, as per the criteria set by the investigators, because they didn't reach the significant survival difference, so it wasn't taken as a positive trial. Technical improvements, they continue. Nowadays, circuits are easy to prime over a period of 10 minutes, and cannula implantation through Seldinger method, EM pump is easy to use the pump, etc. And miniature pumps, they are all some of the developments now, and further developments are going on with respect to miniaturization of the pumps, as well as making more biocompatible circuits. So now low resistance lungs can be used with low pressure, safe pumps, which are less thrombogenic as well. They are inherently safe. Self-regulating circuit needs only a flow switch. So in fact, you don't need one ECMO specialist nurse for each bed. They can look after two beds also easily, thereby reducing the staff need also by keeping the same efficiency. Safe and easy vascular access is possible. The technology will teach itself in this. So looking at it with the progress, we came across a long way, starting from the adult trials in 1972 by putting the patients on ECMO. The first adult ECMO in 1972 by Donald Hill, and then neonatal ECMO by the father of ECMO, Bob Bartlett, in 1972 and 1975, with the further trials in USA and UK and learning by experience through H1N1 pandemic in 2009 to 2010. The whole world learned the importance of ECMO in saving patients with the severe adult respiratory distress syndrome. COVID pandemic in 2020 to 21 has been another eye opener as well, and we are proceeding towards artificial lung. So, lessons learned in the last 5 decades um, about prolonged extracorporeal circulation. Yes, it is possible with minimal complications. Heart, lung, kidney rest with the mechanical support is better than extremes of other forms of management. Critical care grew into a hospital, nursing, and medical specialty. A generation of professionals uh, has a better understanding of the critical care pathophysiology and successful translational research, bringing it back to usage sooner, as soon as it is found to be very useful to the humans in this era of significant diseases by mentoring partnerships, persistence, and dedicated to patient care, good science and clinical trials, clinical practice, putting all these things together, the science has been made more and more easy. So this is the first picture as you have seen earlier. And then towards the 2010, 2012, Bob Bartlett and group from the Central ELSO, they started and realizing the importance of spreading ECMO to the rest of the parts of the world by not only limiting it to USA and United Kingdom. So then uh, in India and subcontinent, we were asked to look after the responsibility of SWAC, that is the South Asia and West Asia. We formed our organization in 2013 to 2014 with the name of SWAC ELSO. Um, Asia Pacific ELSO and Latin American ELSO are the other subchapters of Central ELSO. So now we have 4 subchapters for the Central ELSO. The ECMO centers have been increasing in numbers. As you can see, the whole world has been covered mostly. The active ECMO centers have been growing up as well year by year, up to 18,000 as per the recent figures. The survival rates have also been increasing in individual centers, more so in very well established as well as the high flow centers. The data here is representing the worldwide experience, so it could be dilutional and showing less efficacy in some of the populations compared to expert centers as well. So this is the region of the SWAC also to start with, and then in 2015, Central also has asked Africa to be associated with the South Asia, West Asia region as well. So then we became SWAC, that is South Asia, West Asia, Africa chapter of ELSO. So this is our new logo to the right side in orange color, as we are seeing, with the inclusion of the entire continent of Africa with us too. Our population is 2.56 billion. So no one can ignore the importance of saving critically ill patients in our region. Um, People have been learning and practicing in the best way with the minimal introduction to ECMO Society of India. We started in 2010. It is a great journey in India to improve understanding and practice of ECMO in our country. Um, so the mission was to promote and teach the science of ECMO. The birth year was 2010 and the headquarters has been Ridhivinayak Hospital, Mumbai. So in the last 12 years, we have made lots of improvements and further advances have been made in teaching the technology, taking it to many states, concentrating on the needs of uh, intensivists and cardiac surgeons, in these states. The first conference of national conference of ECMO was held in November 2010. Um, Currently, there are hundreds of life members in the society. We conducted 12 annual ECMO training programs so far, and national conferences too, ECMO workshops and ECMO fellowship program, which has been successfully running. So, this is the growth of ECMO in the world. It is very difficult to define what is the cost of life. It differs from place to place. The take-home message from my talk today is understand the history of development of ECMO and continue to read more about it, as it is fascinating, and it will show how comfortably we are placed on the shoulders of our forefathers who have been working for decades to centuries about the development of this wonderful mechanism to support patients, that to critically ill patients when all other technologies to support life have failed. Uh, Read about the landmark trials in documenting the efficacy of ECMO, and we dealt with the birth and progress of ELSO, or SWAC ELSO, ECMO Society of India, with glimpses on ELSO statistics. If there are any questions, I'm very happy to answer. Thank you for patient listening.